Yes.
Okay,
Yep.
perfect. All right, well, thanks everyone for joining. I know we're a couple minutes past 5, but we got a fair number of folks already. So I wanted to introduce a dear friend of mine, JP Hong from Asan Medical Center. He's our virtual visiting professor for today, at least for this afternoon. For those of you who were with us this morning, we had Dr. Hari Venkatramani from Ganga Medical Center, who is also good friends with JP. I've known JP for a while now. He's hosted me in Seoul at least 3 times, and he's an incredible host. We've traveled together to various parts of the world. This is us, and he likes to take embarrassing pictures of me during travels. I've gotten used to that. And speaking of Hari, this was our trip last year that we went to Ganga Hospital together. And I've also had the privilege of operating with JP and learning from the master himself. So with that, I want to again introduce Dr. JP Hong and thank you for joining us. And I know you're quite busy, given 4 webinars today, and so we're looking forward to hearing. I'm going to give you control now. So give me 1 second here. Let me try to find you on this list. Let's see here. There we go. And make presenter. Okay, so you should get the presenter right now.
Do you guys have my screen?
Yep.
Okay, great. So excellent. What a pleasure and an honor to be with you guys virtually. It's always great seeing Babak and Greg, and hopefully we'll have some fun through this webinar. So today, Babak asked me to talk about lymphedema and how our practice evolved during the last few years. And I know that Dr. Lin over there is also doing quite a bit of lymphedema as well. So it will also be a learning experience for me to learn how you guys are doing. And I saw Babak's case a while back doing lymphedemas for his phalloplasty donor site in the forum, and it was really amazing. So just the basics first. So we all know that the vascular system has basically 3 major vessels. The artery, they supply the nutrients through this capillary system, and then the fluid, the nutrients collects back, and then eventually it flows to the vein and ultimately to the heart, and it flows again. Now 80% is collected back to this arteriovenous system, but 15 to 20% is actually collected by the lymphatic system. And if you look at the lymphatic system, what's interesting is that it has multiple layers of collecting lymphatic vessels. You see those very small lymphatic vessels right on the dermis or subdermis, and then there are relatively larger collecting vessels in the subcutaneous tissue as well. Now keep this in mind, because this is how we sort of looked into looking into various lymphatics, and actually found that the deeper lymphatics are much larger and much easier to handle. So in the beginning, we were trying to do this subdermal small lymphatics, but we slowly evolved in finding these deeper placed lymphatics, which is about double the size, and we really made a lot of things easier. Now, once in the lymphatic system, if you look at the vessels carefully, it's like a vein. It also has valves, so the fluid doesn't, the backflow when you're standing. And another thing is that around the lymphatic vessel, there are smooth muscles trying to squeeze. So there's an intrinsic capability of the lymphatics from their surrounding smooth muscle cells to actually squeeze and push the water toward the heart, push the fluid toward the heart. Another thing is that surrounding musculature also, when it moves, it squeezes the lymphatics, so it's an extrinsic compression. So it also squeezes the lymphatics from the outside, and then it pushes the lymphatics through. Now, you have to understand that there is an intrinsic contraction of lymphatics and also extrinsic. And this is why applying external compression really makes a lot of sense ultimately. And we also recommend patients to exercise quite a bit after the LVA or any microsurgery to improve lymphedema. A lot of the plastic surgeons are just focused in operating, doing LVAs or doing lymph node transfers, but we also have to understand its mechanism to help the patients to have better results. And I think compression and exercise is a key component when you understand the lymphatic system. So ultimately, the lymphatics travel all along, and as they travel, there are multiple lymph nodes in between multiple layers in multiple places throughout our lymphatic circulation. Some of the big collecting lymphatics is the groin, the interpelvic, and then the gastroepiploic. So potentially you have a lot of lymph nodes to work with. And if you look at the lymph node carefully, multiple lymph nodes are going, multiple lymphatic vessels are going into single lymph node, at least 3 to 10, and then you have a outgoing a lymphatic vessel. And ultimately it travels all the way up to the subclavian vein, and then it enters that venous system just before it enters the heart. So that way, the 20% of the nutrient or the fluid being collected by the lymphatic system ultimately joins the venous system. Now, we just talked about the multiple lymph nodes throughout our body, and if you look very carefully, this is where the lymphatic vessels from that region of the skin collects to that lymph node, so-called the lymphangiosome concept. And we use this kind of lymphangiosome concept to actually address what levels to do the LVA, and we'll be talking about that in a minute. Now, the key is to understand why or how the lymphedema happens. So, for example, the most cases of the secondary lymphedema we see are in the extremity, the upper and the lower extremity. So you have to ask, where is the obstruction? In the upper extremity, it's simple. It's in the axilla when they do lymph node dissection. In the lower extremity, most of the times it's in the intrapelvic region after cervix cancer or after prostate cancer, and sometimes it could be in the groin due to malignant melanoma. They remove groin lymph nodes. So understanding where is the obstruction is the beginning of the thinking process, because you have to address where that obstruction is to make this work. Now, because of the obstruction, the distal lymphatic flow starts to accumulate. And as it accumulates, remember, it accumulates in the subcutaneous fat. And ultimately, because of the stagnant flow, it gets inflamed, it gets infected, and goes through that change of that lymphedema. And here, as you can see, this is where most of the fluid is collected in that subcutaneous fat. So here are examples of patients with lymphedema. Primary lymphedema is also seen, upper and lower extremity. Even though intrapelvic dissection is performed, sometimes it could be unilateral, or sometimes it could be bilateral, or sometimes it could be unilateral and then ultimately develop into bilateral. And this is why when you see a lower extremity lymphedema, you always have to test both sides, because a lot of the time, although it may look normal in the beginning, ultimately the patient has a good chance to develop bilateral lymphedema as well. So testing both sides is also very important. For the arm, it's simple because it's the axilla. You'll never get bilateral unless you remove both sides of the axilla, axillary lymph nodes. So again, the primary lymphedema is relatively rare, but we do see it in our clinic. I think you also have to understand there are multiple pathologies for primary lymphedema. Now, when I first started to do lymphedema, I asked Dr. Kushima, hey, can we operate on primary lymphedema? And he says, if you operate early, then it's doable. And we agree with this notion, because if you look at primary lymphedema, there's basically three, in our opinion, I think there's three subsets. First is the lymphatic system agenesis. So this primary lymphedema doesn't have any lymphatic systems from the beginning in the extremity that's involved. So in these patients, there's no chance of doing a lymph node transfers or LVA because there's just no lymphatic system. Second, there's a lymphatic system, but it's dysfunctional. These are the patients that you could actually do LVA and lymph transfers to. And then finally, there's a mix of dysfunction and agenesis. So screening the patients and trying to figure out what pathology they have for primary lymphedema makes a huge change. So understanding that, now we're starting to do LVA in 7-year-old or 8-year-old primary lymphedema cases as well, because we know that once we do the testing, which we'll be talking about later, it gives us a better understanding of how to approach the lymphedema. If there's no lymphatic system, or if the lymphatic dysfunction is so severe, then of course then we do debulking surgery like liposuction. And of course, we just talked about secondary lymphedema, and when this progresses, of course, the fluid accumulates, and then ultimately it tries to leak out because it cannot accommodate any more fluid. And this is a very common skin change that we see in our stage 3 patients. These patients will also undergo cellulitis and even turn into a malignant skin cancer. So making sure that we're able to solve this kind of problem before it becomes this severe is part of our goal. Also, we do see a lot of lymphedema from trauma, especially when the trauma involves the inner thigh. And then the patient may undergo lymphatic obstruction in the inner thigh level, and then ultimately develop post-traumatic lymphedema. Sometimes we also see it in DVT or in patients that underwent radiation. Now, what's really interesting about radiation is that when we look at our data, patients with radiation has a higher chance of developing lymphedema ultimately. So it may not have immediate lymphedema after lymph node removal, but after several years, 7, 8, 9 years, there's a chance to develop slow lymphedema. So when patients do have radiation, now we're telling the patients to observe their limb, their arm or their leg, and when they start late lymphedema, to come to the hospital as soon as possible. So we don't want to lose that window of trying to do LVA in a good functioning lymphatics. Now, most of the patients, the good news is that most of the patients who develop early lymphedema due to lymph node resection and secondary lymphedema, 85 to 90% will have positive response to decongestive lymphatic therapy. So if you think about it, if the towel's wet and full of fluid, the only way to squeeze the water out is, squeezing the towel. So that's what decongestive therapy is. It's just squeezing the water out from the involved limb, affected limb. So it's basically compressing and bandaging, and then manually trying to squeeze the water out. And the good news is that 85 to 90% of the patients who has early lymphedema, so early stage 1, is very responsive, and they'll be able to recover from the lymphedema. So when you see results of patients, when you see a surgeon saying, "Hey, look, I did stage 1 lymphedema," the first thing I asked was, "Hey, did the patient undergo decongestive therapy or compression?" If they say no, then how do you know that this was going to be spontaneously resolved? So our protocol, understanding this, always sends early stage 1 lymphedema to our rehab. And if the decongestive therapy doesn't work for 6 months, then the patient is indicated for surgery. Or if the patient is time sensitive, has a job that's time sensitive, then we may consider doing LVA. But other than that, so at the end, we rarely do any stage 1 lymphedema operations unless the patient failed to the decongestive therapy, and that's around 10 to around 15% of stage 1 lymphedema. Now, so when these patients are not responsive to decongestive lymphatic therapy, ultimately they'll have to undergo decongestive or a compression bandage for the rest of their life, because if they don't do it, then it collects fluid again. So it's a very troubling thing, especially if you're living in a hot country, the Middle East or in Southeast Asia. It's almost impossible to see good compliance to compression therapy. So it becomes a very difficult job for them. And because of their poor compliance, as long as they're compliant, we've seen patients who had lymph node dissections 20 years ago and they're still relatively supple. So compression really, really helps to maintain a supple limb. But if they're not compliant, they'll start to collect fluid, and then 30% will start to have recurrent cellulitis, and ultimately even have sarcoma, not to mention the disfigurement, and sometimes they have to undergo amputation. So this has been a very long quest to solve the lymphedema problems, because if we look at documents, it's really interesting to see. When I visited the Cairo National Museum, they actually have one of the pharaohs with lymphedema, and it actually says this pharaoh had lymphedema. It's probably infected from the filariasis, but nevertheless, this was a problem of thousands of years ago. So a lot of the quest to solve this was really there for a long time. But now, understanding the microsurgery and starting to manipulate small vessels, now we might have a permanent solution that actually mimics the normal pathophysiology of the lymphatic system, and really tries and have a good solution. Now, in the past, most of the surgical approaches were debulking, and debulking is still used today when reconstructive measures are not doable. A partial excision, as seen in this patient here, and we all know that ultimately the collection of the fluid is in subcutaneous fat. So the goal of debulking is actually trying to get rid of that reservoir, that subcutaneous fat space for the fluid to collect. So theoretically, if you get rid of all the space, then there will be no fluid collection. So here's a patient that underwent debulking a decade ago, and then the patient came back with this recurrence to our hospital, and then you could see that the places where the debulking was missed actually have this kind of recurrence. And then we went ahead and we did a little bit more debulking, and at the same time we did LVA. So the patient is relatively maintained well, but nevertheless, if you don't do LVA, the patient has to undergo compression for the rest of his or her life after the debulking. Now, an extreme form of debulking is the Charles procedure. Basically, what Charles procedure is doing is removing all the subcutaneous fat above the deep fascia, and then harvesting the skin from that removed tissue, and then just putting a skin graft on. So this patient will never have lymphedema because there's no place to collect the lymphatic fluid. So we solved the problem. But aesthetically, this patient will not go out before the surgery or after the surgery. Look at the disfigurement. Although we fixed the problem and the lymphedema is not there anymore, the patient will have a very poor quality of life. But this kind of surgery is needed to avoid further exacerbation from lymphedema that cannot undergo LVA. So looking at from this cosmetic, then we went into the period of doing a lot of liposuction to really have a good appearance after the result. But of course, there's a limit to how much fat you could liposuck. But nevertheless, this is a very good option in patients that are not able to do LVA or lymph node transfers, as this seen in this congenital lymphedema patient here. But nevertheless, after the liposuction, this kid has to undergo compression therapy for the rest of their life. Another quick fix that we found very useful in patients with active infection or inflammation during the cellulitis period is just making a quick incision underneath the skin and undermining the subcutaneous fat region, and then just putting a back with negative pressure wound therapy on. It basically sucks out all the fluid, and then you're able to get rid of that acute inflammation in 2 or 3 days. And the amount of fluid that comes out is significant. But after the removal, physically removing the fluid, again, this patient after repair has to undergo decongestive therapy. So here you could see immediately after the cellulitis is improved. The patient doesn't have to take prolonged antibiotics. and we're able to actually see quite a bit of reduction, but nevertheless, this is not a permanent fix. So these modalities of temporary fluid release or debulking, most of them, with the exception of the Charles procedure, will need a lifelong compression. And if you become in contact with lymphedema patients, their biggest complaint is being compliant to these kind of decongestive therapy, and you know how much their life quality, especially during summer times, is really poor. They have dermatitis, they have problems with their skin because of this continuous compression therapy. So ultimately, a lot of surgeons start to ask, hey, can we have a permanent physiologic solution that increases the quality of life? And this is where LVA and the lymph node transfer comes in. And I think as reconstructive surgeons, that we have this kind of armamentum really helps. Now, in the beginning, we said how the lymphatic fluid circulates in our body, and ultimately it drains to the vein. So basically, it's using this idea, distal to the obstruction, and actually reestablish the flow between the lymphatics to the vein. And that's how the idea of doing LVA comes. Also, if you think about it, when you think about doing lymphatic lymphovenous anastomosis, I mean, during our cadaver dissection days in med school, I mean, I don't think I've ever seen a lymphatic vessel in an extremity. That's how small it is, and it sort of becomes very challenging. But in the past, there were surgeons who were actually using this principle, but connecting the node to the vein, and shown some good results. But ultimately, it was unreliable because sometimes it was good, sometimes it wasn't bad, and then this practice was abandoned quite early. And we'll be talking about that as later on as well. And another way to approach this is replacing with what is missing. So this is where the lymph node flap comes in, and basically reestablish. They put the lymph node in the place where it's missing, and then hopefully lymphangiogenesis occurs, and it reestablishes the flow. So all these three modalities, lymphatico LVA, lymphatic-venous anastomosis, lymph node to vein, lymph node flap, requires some microsurgery. But when you're doing LVA, you're now going into a more smaller dimension called the supramicrosurgery, which is surgery of manipulating vessels of less than 0.8. Now, with better instruments, this manipulation of small vessels has become much more easier. With better instruments, smaller sutures, and with the help of the ICG imaging, this really became doable. So today we're going to be reviewing these three modalities, microsurgical modalities: LVA, lymph node to vein, and doing lymph node flap. So let's start with LVA first. So this is a typical approach of doing lymphatic-venous anastomosis, Dr. Kushima style. So you're starting to open the skin under the microscope. Here we are using immunofluorescent dye. This is a common dye used by our ophthalmic colleagues. And this is a 6-0 nylon that you see. So you could imagine how small this vessel is. And then once you find this lymphatic vessel and a capillary vein, you're connecting this lymphatic vessel to the vein. And the idea here is that high pressure lymphatic fluid will flow into a lower pressure vein. And as you can see here under the microscope, so we're doing both ends of the lymphatic vessels, and you could actually see the vein turning yellow because of the high pressure vein, because of the high pressure lymphatics, and ultimately this is how you do LVA. And when you're doing this kind of subdermal lymphatics, it's really painful. But before we go on a little bit more, let's think about how this works. So it's basically, simply put, it's using a pressure gradient between the lymphatics and the vein. Now the vein, when you're lying down, is about 20 millimeter mercury. So this is why when the patient with lymphedema, one of the questions we ask is, hey, in the morning, do you have, relief of the swelling? Does the swelling get a little bit better? If they say yes, it means that the lymphatic somehow flow is still working. And it gets better because the reduction on the venous capillaries is lower at night. So thinking about this, after LVA, we always we also tell them to do congestive therapy. I mean, tube bandaging at evening as well, because with the low pressure vein, we know that there will be more a better lymphatic flow going to the vein. So we emphasize on doing night compression therapy at night after the LVA as well. Now, as the vein flows a little bit higher, the pressure becomes lower and lower. And then ultimately at the right atrium, the pressure is 2 millimeter mercury, which is much lower than the lymphatic pressure. So this is why when you do LVA for the arm and for the leg, you have much better results with the arm, because physiologically, the venous pressure is much lower. This is why, because the venous pressure is higher in the lower limb, this is why the lower limb is more challenging to have better results compared to the upper arm. Now, when you're standing, however, it's a different story. The venous pressure elevates to about 90 to 110, and if you're moving, however, because of the squeezing, external compression of the muscle, the pressure becomes very low. So hence, during the day, hey, look, use the compression and do a lot of exercise under the compression, and the lymphedema after the LVA is able to improve. Now, if you look at lymphatic pressure, normally it's around 12 to around 70 millimeter mercury. But when there's an obstruction along the lymphatic pathway, for lymphedema patients, the pressure becomes high as 200 millimeter mercury. So this is why LVA works, because once you connect, the high pressure lymphatics flows in to the low pressure vein. But as you can see, then the question you have to ask is, okay, so the lymphedema patient is getting better during the first few months, and the pressure is becoming lower. And when the pressure becomes almost the same as the vein, then theoretically it shouldn't work anymore. And this is why external compression becomes very, very important, because you want to keep on creating that pressure gradient until you get the maximum improvement after LVA. And this is why I emphasize strongly in doing compression garments and also doing exercise, because when you know this physiology, it just makes better sense. And also looking into this, and if you look at the curve of the rate of the improvement is significant in the first month, and then it's a gradual change, because early in the after LVA, the lymphatic pressure is high and it's exiting like crazy, but as the pressure becomes equal as the venous pressure, then the improvement becomes slope becomes pretty horizontal. So this is why maintaining compression after that first month, continue to do compression for at least 6 months makes a lot of sense to improve the lymphedema ultimately. So what happens to the lymphatic vessel as the lymphedema aggravates? And there's a lot of study, especially a study by this Japanese group by Dr. Mihara, and it has actually shown the fate of the lymphatic vessels as the disease progresses. The normal lymphatics on the left, you see here, it's a transparent vessel, but as the lymphatic pressure goes up in the beginning, the lymphatic vessel sort of becomes dilated because it's trying to accommodate more fluid. So, and ultimately, this is the kind of vessel that you want to work with if you have. But as it aggravates, it starts to have perivascular scarring, sclerosis of the lymphatic wall, and then ultimately in stage 3, the sclerosis is so bad that the lumen is actually shut down, as you can see here in this histology as well. So the goal of doing lymphedema surgery is finding good functioning vessels, which we'll talk about later on. And if you're able to find that, it makes the LVA much easier. Second, for us, is also understanding the location. Now, remember, we talked about the ones that are located very superficially, subdermis, and then the ones that are located a little bit in the deeper fat. So we try to always find the ones that are located in the deeper fat because it's just larger, and it's almost double or triple the size of that superficial lymphatics, and those becomes very easy to manipulate. So the goal is to find lymphatic vessels that are larger, located in the deeper lymphatic, deeper subcutaneous fat, and the ones that actually have functioning lymphatic vessels. So the one with dilated lymphatic vessels are probably the best way to do the LVA easiest. What about the vein when we're doing LVA? So the important thing is sometimes you open the skin and you find beautiful lymphatics, but you don't find any vein, and that's a painful situation. So when you do LVA, you always have to think about where the vein is going to be, and we'll discuss in a bit how to do that. Of course, if the vein has minimal backflow because of the resistance of the after doing LVA, it's better. If there's a lower pressure vein, it's also good. And I also like to use the side branch of the vein. If you hook up the vein end to end, of course this works as well. But if you hook up to a branch, it sort of creates a Venturi effect. So it sort of sucks in the lymphatic flow, which I'll demonstrate in a minute. The way we do LVA, you could do end to end, side to end to side, and side to side. Now, here are multiple videos showing how you do LVA, side to side, end to end. And when we do end to end, we like to take both ends of the lymphatic vessel, because what happens in the lymphatic as the lymphatic vessel changes, as the lymphedema aggravates, is that it loses the valvular function. The first thing that goes away is the valvular function. So you actually see backflow of the lymphatic vessels as the lymphedema gets worse. And this is why you should connect both ends of the lymphatic vessels. And if you think about it, but if you connect it to the side of the lymphatics with a vein, so side to end, then you're collecting from both ends, from the distal and the proximal lymphatic vessels. So this is why we now prefer side to end, opening the side of the lymphatics and connecting the vein. So we're collecting from both ends. And this has been our approach, unless the vessel is super small and we cannot open the side. Now we're just doing a lot of side to end. And when the lymphatic vessel is large enough, as you can see in the left upper corner, side to end becomes very easy. So here, when we expose the lymphatics, I like to use a patent blue paint around the wall of the lymphatics, because it just gives you a better idea on where the vessel wall is. This is a nice trick that I use. And then you open it up, and then you dilate the lymphatic vessel, and then you ultimately you hook up the end of the vein to the side of the lymphatic vessel. Sometimes this vessel is so small, even with a super microsurgery dilator, that you have to use one blade to dilate first, and then you put both blades in to ultimately dilate the vein. The same thing with the lymphatic vessel. You dilate the lymphatic vessel as much as possible to make the suture easy. And when you dilate, you rarely need 12-0 sutures. The last time we used 12-0 is probably for a vessel that was probably 0.2 or 0.3. So here now we're opening the side of the lymphatic vessel, and you can see that the patent blue sort of makes it easier to distinguish the margin of the vessel wall. So now you clearly see the margin, and then we put a dilator in to dilate the lymphatic vessel. And once that's dilated, then we go ahead and start suturing with a 11-0. And again, side to end is now the preferred method for all our LVAs. So here, so we've connected. This is the branch of the vein. So here we connected to the side, and look how when the lymphatic flow goes into the main vessel, main vein, look how it's being sucked up. So that's the Venturi effect. So when you have that big venous flow and you're adding the flow, the lymphatic flow gets sucked up to the vein. So this is why we try to avoid using the end of the vein, but instead try to use the branch. So when you hook up the branch, the lymphatic fluid gets sucked in to the larger vein, creating a Venturi effect, and hopefully creating a better result. So the idea here is use the vein branch and cut that vein end, and then hook it up to the side of the lymphatic vessel has been our major approach to do a lot of LVAs. So here, LVA this is a stage 2 patient. And if you look at the literature, they say to do LVA in stage 1 or stage 2 early. And as we're doing more LVAs, and the reason why they say this is because we just talked about how this. Also, this is for you, Babek, genital lymphedema. We made a direct incision on the scrotal skin, found good lymphatic vessels, and then basically hooked up the vein to that lymphatic vessel, and then we're able to have this kind of result after 6 months. This is a foreign patient, so I haven't been able to see him after 6 months. But since he's not sending me any emails, I'm presuming that his result has gotten better. Hopefully, I'll see him soon. And the reason why they say to do LVA in only stage 1 and stage 2 is because we saw what happens to the histology of the lymphatic vessel as the lymphedema aggravates. It becomes sclerotic. And sometimes when you try to hook up the lymphatics and when you cut the lymphatic vessel, you don't see any fluid coming out. So this is why stage 3, if you look at a lot of literature, they say don't do LVA. LVA is not going to work. But for this patient in stage 3, what we really found out as we're doing more and more cases is that although the transgression from stage 1 to stage 3 does follow this pathology and does follow this change of the lymphatic vessel, what we found is that even in stage 3, this is not a staged change. Sometimes you see this kind of hepatic dilated lymphatics in stage 3 as well. Now, the majority of the lymphatics underwent changes like this and have sclerosis, but some also has this kind of dilated lymphatics because there's so many lymphatic vessels. Some are aggravating quickly, some are aggravating slowly. And if you're able to find this kind of functioning lymphatics in stage 3, then we actually saw that LVA does work for stage 3 as well. So here for stage 3, patient with an LVA, this is a 5-year result, and the patient is off compression. Now, why is still there asymmetry? It's because of stage 3, there's a lot of fibrotic change because a lot of the subcutaneous tissue becomes fibrotic. They undergo fibrosis, and ultimately that part will not improve even after the fluid is removed. So if the patient wants to further improve their appearance, then this is when liposuction comes in. Try to liposuck the fibrotic tissue, and then I could have better improvement. But nevertheless, this patient is off compression and has a significant improvement in her daily life. So we found out for stage 3 that it also works. And this is a patient with stage 3 again, just doing LVA. This is an immediate result after 1 week. And then ultimately the patient will continue to improve. So we actually looked at our data for late stage 2 and stage 3, and then we saw that we do an average of 4 to 5 LVAs per limb. And then the functioning lymphatics were found in most of the cases. In 20% in stage 3, you will not find functioning lymphatics. And in 80% of the time, you will find, according to our statistics. And when you find it, the vessels are relatively functioning, large, and easy to do LVA. So we had a significant improvement after doing LVA in late stage 2 and in stage 3 as well. And this will be published in TRS soon. So this is a typical approach of our stage 3 patient. Are you guys getting the audio of this video?
Yeah, we're not getting the audio.
Okay. So the question, so a lot of the times the question we are approached is, and we'll be talking about this in a minute, is when you see this ICG pattern and say, oh, it's a splash type, and they say, oh, there's no functioning lymphatics, and you have to ask yourself, okay, how do you know? I mean, the subcutaneous tissue for stage 3 patient could be 5 centimeters, 4 centimeters, because the ICG only shows up to 1 centimeter. If you're lucky, 1.5. So how do you know what goes on in that remnant, the rest of 3 or 4 centimeters? So ICG is just an interpretation of that subdermal lymphatic system. So we don't do ICG anymore for stage 3 patients, and we'll be talking about what we do. So basically, all the stage 3, you'll see the Stardust pattern. But ultimately, what we do is we for stage 3 patients now we do this kind of MRI, and the MRI actually allows you to detect these deeper lymphatic vessels. And when we see this deeper lymphatic vessels, then we know, there's a special offer. Okay, what is it? Okay, so there's a deeper lymphatics, and when the MRI actually shows that, then we say, okay, this patient may have a functioning lymphatics, and then we go ahead, bring in the ultrasound, and using the ultrasound, we're able to see this lymphatic vessel. And with the ultrasound, you actually see the nearby vein as well, and then we know, here, look, there's a vein, and there's a lymphatic vessel. So using the ultrasound and identifying this lumen, we're able to know that this is a functioning lymphatics. For the sclerosed lymphatics, this is white. It looks like a white dot. So we know that it's not functioning. But when there's a lumen like this, then we know that this is a functional lymphatics. We try to find a nearby vein, and then you just have to make 1 or 2 centimeter incision, and then you basically do a quick LVA. So using this ultrasound really helped our practice a lot to make it efficient. At the same time, to find functioning lymphatics. So here we make the incision under the microscope, and you could actually see the superficial lymphatics that has uptaken yellow dye. But again, we're not using this smaller lymphatic vessels. So basically, we're going in all the way to the subcutaneous fat, going through this subdermal tissue. So here's again a lymphatic vessel, just cutting through them. And while we're cutting through, we're also looking at the veins around, and you can see a very clear vein right here. So now we're going through the superficial fascia, and just under the superficial fascia, usually that's where the deeper lymphatics lie. So here, we've marked it with the we actually saw it with the ultrasound. And then we're trying to approach the functioning lymphatics. Here, the deeper lymphatics. So we're just going through, and then once we're in the subcutaneous fat, we find this very typical, a very nice lymphatic vessel with a good uptake of that immunofluorescent dye. And here's a second lymphatic vessel right here. So we've identified 2 lymphatic vessels. So here is the deeper, here's the vein with 2 branches. So we're going to be hooking it up on the side of the lymphatics. And look how large these vessels are. So it makes it very, very easy. Instead of doing a very painful 0.3 anastomosis, you're using this with 0.5 and 0.6, and basically we've hooked it up to the both ends of the lymphatics. So the idea of doing LVA, even for stage 3, is creating that shunt and using that high pressure lymphatics to the low pressure vein and causing to improve the symptoms. And the symptoms improve in 77%. Also, in the cellulitis has a significant reduction after LVA. Their symptoms may not improve. What we found is that their symptoms may improve a little bit, but their numbers of having recurrent cellulitis improve significantly. So even if the patient doesn't have any cellulitis, this is a huge improvement for them because they don't have to go to the hospital every few months and have antibiotics. So that itself is a huge improvement as well. So the question is, then how do we find functioning lymphatics? And we just talked briefly of using MRI and using the ultrasound. Let's go in deeper and look at the modalities we have to actually diagnose lymphedema patients. And the most common thing we use is lymphatic scan. So here, what it's telling you is that there's a fluid collection on the right side, and on the left side, the clearance is pretty good because you see that uptake in lymph node. But on the right side, we know that the fluid clearance is very slow. What other information is it giving you? Not really much. Sometimes you're able to see larger lymphatic vessels take up, but you're not able to actually identify where it is, nor are you able to see smaller lymphatic vessels at work. ICG is a great modality in stage 1 or early stage 2. So we do use ICG. And again, the level of the penetration is only up to 1 to 1.5 centimeters. So we don't actually know what goes on underneath that 1 centimeter. So ICG for us is a modality that we use for stage 1 or to do stage 2 early. When the patient starts to aggravate to late stage 2 or stage 3, this is where the MRI comes in, and you could actually see the MRI showing nice lymphatic vessels, and then we're able to know that there is functioning lymphatic vessel in this patient. And then once we do that, we bring in the ultrasound. Also, you could do isotope and use this gamma probe and actually trace the lymphatic vessels. Now we use this mode, and we'll explain a little bit more in when we do lymph node to vein. So we know that when you trace the gamma probe, and when you hear the sound all the way to the node, we know that the lymphatic vessel is working. And then we see a hot uptake node, and then we're able to take this node and do a lymph node to vein anastomosis. So that way you don't have to do LVA distally, because we know the lymphatic flow is working all the way to the node. And this is when we do lymph node to vein. Also, you could use this to do reverse mapping when you need to harvest the lymph node from the groin and actually take the one with the minimal uptake. So that way you're able to preserve the lymphatic function of the lower extremity while taking the lymphatic vessel, while taking the lymph node. So here is how we further identify functional lymphatics for late stage 2 and stage 3. So using the ultrasound, you're actually able to map out this dilated lymphatic vessel. So here is that dilated lymphatic vessel, and here's the vein as well. Now, with the regular ultrasound, using 12 to 15 megahertz, it's a bit difficult to identify these large lymphatic vessels. So now we're using 45 and 75 megahertz ultrasound. This is specifically made to actually locate that lymphatic vessel. And this has really, really changed our life dramatically. It's just easier. We know where the vein is. We know where the lymphatic vessel is. So we basically map it, incise it, plumb it, and then we just come back. And then that's it. Using the ultrasound really has reduced a lot of time. And here you could see a more clear picture with using a 70 megahertz ultrasound. So the key in using this ultrasound is to identify the deeper, larger lymphatic vessel. We know, and to identify the functioning ones, and also identify the closest vein near that functioning lymphatics. So using the ultrasound really has changed our practice significantly in lymphedema. Of course, we also use the ultrasound to map perforators in all our flaps nowadays. So we rarely use handheld Dopplers anymore. So the main modality of the study is the ultrasound for our flaps and for lymphedema patients. So among all the studies, I think, there's no universal study, but depending on the severity, then you have to choose what study is good for this patient, and ultimately and do the study to evaluate and reach the goal of finding that functioning lymphatics. Now let's move on to lymph node to vein. So basically what this idea here is just understanding where the level of obstruction is. Now for the upper extremity, they move all the axillary nodes, and so you don't have any lymph nodes left to hook up to. But for the lower extremity, a lot of the times, the lymphedema happens after cervix cancer, after removing the uterus, ovarian cancer, or for prostate cancer. And these cancer patients are actually removing the lymph nodes in their abdominal cavity, in their intrapelvic lymph nodes. So theoretically, the obstruction is here at the level of the abdomen. So theoretically, the lymphatic flow should maintain all the way to the abdomen. And if you look at these patients, the groin lymph nodes are all very, very healthy. But as these patients progress, their degeneration of the lymphatic vessels and the lymph node occur. So when you look at this ultrasound, we know that on the left side there's definitely lymph node. If you look at this lymph CT scan, but on the right side, just because it doesn't take, it doesn't mean that the lymph node is there or not. It's just showing the flow. The flow is slow, so that's why the lymph node is not lighting up. But if you look at the MRI for these stage 3 patients, some of them are actually degenerated. The lymph nodes are scarred, so there's no lymph nodes left. But some patients actually have good large lymph nodes. If they do have large lymph nodes, and we found out more than 8 millimeters, this is also in press, then we know that this lymph node is functioning, and then we basically make a hole, and then we hook up the vein. So this is a sort of an LVA, but a macro microsurgery. So here in the past, using this idea is not new. In the past, they actually they cut half of the lymph node and preserve the afferent, the ingoing lymphatic vessels to the node, and then actually hooked it up to the femoral vein. Sometimes it worked, sometimes it didn't, because sometimes the lymphatics are degenerated, sometimes they're not. So, and then this is also a Takumi, a good friend of mine. His style is finding the lymph node and then hooking it up to the efferent lymphatic vessel. But our modification is making a hole in the lymph node and then putting the vein, and anastomosing the vein to the lymphatic capsule. And this idea is because we know that as lymphedema aggravates, the valvular function goes away, and then the flow comes from the distal and the proximal. So we're trying to capture as much lymphatic flow as possible going into the node, and then ultimately hooking it up as a lymph node vein, as you can see here, catching both efferent and afferent vessel. So here's a quick video of how to do lymph node to vein. So basically, as we're dissecting, we've identified a nice superficial vein, and then basically using the superficial vein to hook up the node. And when you try to find the node here, you could see the capsule. It's very important that you do minimal dissection, because if you do a clear dissection, then there's a good chance of actually cutting the efferent and the afferent lymphatic vessels going into the node. So after making a small puncture, you could actually see the lymphatic fluid coming out from that lymph node. And once you identify this lymphatic fluid coming out, then you basically hook up the vein to the capsule of the lymph node. And this is a very simple surgery. It's using the same idea as LVA, and now you can see more fluid coming out like crazy. And then and this is just a simple surgery. So as long as the lymph node is functioning, you're actually hooking up multiple lymphatic vessels to that vein. So that's the idea. And our data actually shows that when we're able to find functioning lymph nodes and hook that lymph node into the vein, the thigh has a much faster improvement. Also, the overall extremity also has a significantly better improvement compared to the ones that we did just LVA on the leg, and compared to the ones that we did lymph node to vein at the same time LVA to distal limb, we actually had a better result. Also, lymph node to vein is an must anastomosis if the patient has a genital lymphedema, suprapubic lymphedema. And if these patients are complaining edema in the lower abdomen, then this is a must-do operation. So again, the findings that we saw, a significantly better reduction of the whole extremity, also a significantly faster reduction of the thigh region by hooking up the lymph node to vein. Now, in stage 1 patients where we find nice lymphatic flow all the way to the node, then we just do lymph node to vein, and we're actually able to see improvement as well. But for stage 1, we rarely see stage 1 anymore because, again, because of the compression, it really relatively works well. But nevertheless, for the 20% of the patient that does not work well to decompression therapy, then we go ahead and try to do the lymph node to vein if the lymph node is working. That way, then we don't have to do LVA in the distal leg. So a couple of cases here, as you can see, improvement prior and after doing LVA and lymph node to vein as well. Now, finally, let's move on to lymph node fat flap. So it's again taking the lymph node as a flap, and then we're hooking it in to the artery and vein. So this is a simple idea, replacing what is missing, like with like. And basically, for the upper extremity, when we do see a lot of scarring in the axilla, we always do lymph node vein. So for the stage 2, lymph node flap. For the stage 2 and 3 for the upper extremity, now our protocol has changed. In addition of doing LVA, we always open up the axilla, remove the scar, make a large pocket, and then we put in the flap. And also what's important is that we also found out, and this is also agreed upon among many lymphatic surgeons, is that you must reconstitute the fat-to-fat connection, because you have to have fat for the lymphangiogenesis to occur. So you have to make sure when you have that large pocket after you remove the scar, you put in a flap that's large enough to reconstitute the fat-to-fat contact in the axilla. So basically, after removing the scar, making a large pocket, elevating a large fat lymph node flap, and you basically harvest it, and then you hook it, and this is the basic result. You could see the severe scarring in the axilla, and then we basically put it in. Also, you know, there's a lot of group that actually does this simultaneously with the DIEP. Our breast reconstructive surgeons have found this actually hooking it up to a DIEP very, very difficult to model the shape of the breast. So in the beginning we used to do it as part of a DIEP. Now we do it separately. So we're doing 2 separate flaps so the breast could have the best appearance after the surgery, and then we harvest the fat from the groin area, and then we hook it up to the axilla. For the lower extremity, think about where the level of the obstruction is. The level of the obstruction is in the abdominal cavity. So it doesn't make really sense to put it in the abdominal cavity. So basically, you have to put it somewhere else. And for this lower extremity, nowadays we rarely do lymph node flaps for the lower extremity. But if you think about it, where do we put it? So either you put it in the groin or the ankle. But if we do have to do lymph node flaps, we like to put it in the ankle because it's just easier, and the dissection is easier. So we just like to put it in the ankle. But again, we rarely do lymph node flaps for the lower extremity now. We basically harvest for the arm, for the upper extremity lymphedema, we basically harvest the skip. We deepithelialize it, and then we put it in the axilla. For the lower extremity, if we need to do lymph node, we basically harvest it from the thoracodorsal chain. So that's a very easy harvest. You could do it omental, submental, supraclavicular, whatever you're comfortable with. But I find it personally easy doing it from the groin and doing it from the thoracodorsal chain. So here's a typical example of elevating the lymph node, again, incising in the groin, going through all the way to the superficial fascia. And we know the lymph nodes are located in the deep fat. So once you cut that superficial fascia here, as you can see, we basically elevate a chunk of the fat in the lymph node. We're making sure that we're not taking any big functioning lymph nodes from the extremity. And these are usually in lateral to the femoral artery and vein. So here, quick harvest of the fat, and then ultimately taking it. So you have to take a lot of it if you need to if you need to obliterate a large space. So now in most of our cases, we harvest this large deepithelialized skip flap to hook it up to the axilla. If you need a smaller one, you could take a smaller lymph node flap as I just shown you in the prior photo. So again, emphasizing the important steps, complete scar removal. You know, you'll be surprised to see sometimes, you know, it looks very supple in the axilla when you do a physical exam, but when you open it, it's always scarred, very severe scarring. Identify the recipient vessel and then hook it up and then transfer the lymph node flap, and this is the results. So again, for the upper arm, we always transfer it to the axilla. I know that Minghui from Tangun likes to do it in the wrist. For me, I mean, we're opening it to remove the scar anyway. So, you know, I don't want to cause an additional incision. But again, whatever's comfortable with you. He has shown data clearly that the wrist also works. For the lower extremity, it's the groin region or the ankle. But for me, in cases that I have to do lymph node flap, I like to go to the ankle because it's just easier compared to doing it in the groin, and there could be some potentially functioning lymph nodes. It just doesn't make sense to me to injure the lymph nodes to put in extra lymph nodes. So again, this is a case that we put in the ankle of the lower extremity, and this is the final result. You can see that improvement does happen, but it happens much slower compared to the LVA. Now, there has been modifications of the lymph node flap. I know that Dr. Kuchima and Wei from Mayo likes to do lymphatic duct transfer. So this is basically taking fat with the lymphatic chain without any lymph node and putting it as a flap. There's no clear paper to support this yet. Hopefully, we'll see some more data to see whether or not this really works. There are also a group of people who likes to take the lymph node with that lymphatic vessel and then hook up that lymphatic vessel to the end of the lymphatic vessel in the recipient site. I think that's also a good idea. It may take a little bit more effort to identify the lymphatic vessel in the axilla, but nevertheless, I think this is a great idea as well. So our first choice for the upper extremity is LVA with lymph node most of the cases. For the extremity, it's always LVA or lymph node to vein. But again, I think we have to customize every approach accordingly to the patient's condition. So again, when you do lymph node flap, you have to tell the patient that the change is going to come slowly after 3 months. As when we do LVA, the change comes immediately, even after the day after the operation. Post-operative, again, I cannot emphasize more. I mean, I know that there are groups that say you don't need compression. I totally disagree. Our early series without compression actually shows a much less response compared to our group with compression. I think compression is key to create that pressure gradient. Of course, that you have to document how much improvement you've made. Nowadays, we're using 3D camera to actually see the volume of the extremity. That has really given us better data as well. But you could also use bioimpedance test. Also document the number of cellulitis, and you can manually measure the circumference at multiple levels to actually see the improvement. Our result has shown that 97 believe that they've been improved because they basically had, the feeling of improvement is huge because this was a surgically neglected problem for a long time. 78% have objective improvement, and 41% will achieve near normal improvement when looking at our whole lymphedema series. I think the key physical finding to do any LVA is pitting. If you don't see pitting, then you have to consider debulking surgery. So looking at the algorithm of our upper extremity, always non-surgical approach first, send it to rehab unless it's a stage 3. And then if the rehab doesn't work, then we think about surgical approach. It's either LVA alone, or most of the times in upper extremity now is LVA plus lymph node flaps simultaneously. And then if that doesn't work, we might try another LVA. If that doesn't work, then we have to consider debulking procedures such as liposuction. For the lower extremity, it's for stage 1, non-surgical. If that doesn't work, surgical. We like to do LVA and lymph node to vein simultaneously. If it's stage 1, then we only do lymph node to vein. If that doesn't work, then we may consider lymph node transfers as a separate secondary procedure if the LVA or lymph node to vein anastomosis doesn't work. And if the lymph node transfer doesn't work, then ultimately we'll consider liposuction. And for additional debulking after improvement, if the patient wants to remove that fibrotic segment, then we also may consider liposuction. There's some exceptional approach for patients with malignant melanoma. Sometimes what we do is we harvest the skip flap with the lymph nodes, and we just put it during the reconstruction. And we've actually seen transient lymphedema ultimately get better as the days pass with this kind of approach. Here's a patient with radiation injury. after sarcoma, getting radiated and then having radiation injury. So this case, again, we tried to skip flap with the lymph node. The patient had improvement of the lymphedema, but unfortunately the margin of the wound also broke down a bit. There are new approaches that are coming, and I know that there's a multi-center clinical prospective clinical trial with preventive lymphatic surgery. So this is hooking up the lymphatic vein, doing an LVA simultaneously as the lymph node is being resected. We've been doing in our breast cancer patients as well as our OBGY cancer patients as well, and we're also waiting to see preliminary results. Now, you have to think about the overall number of the effect that this may bring. Now, when the patient removes the lymph node, around 20 to 30% may develop lymphedema. And then in that 30% that may develop lymphedema, after compression therapy, only 10 or 15% may develop lymphedema. So of all cancer patients, we're looking at 1% that may develop lymphedema that needs surgical intervention. So is doing preventive surgery worth it? So that's the key question, and that's why I want to see more data regarding this before I'm confident of doing LVA, preventive LVA for this population. So today we talked about what is lymphedema, how does it work, how does the surgery work, the importance of rehab, compression, and also the treatment options, and ultimately how we approach lymphedema in the upper and lower extremity. In the beginning, where I learned from Dr. Kushima in 2005 of trying to do LVA, it was crazy, trying to hook up that little 0.3, 0.4 subdermal lymphatics to the vein system. I mean, when I first went there and I was being taught by Dr. Kushima, he would dissect and say, "Hey, JP, this is the lymphatic vessel. Do you see it?" And I'm looking there under the microscope and I'm saying, what is this? The lymphatics. I go, "Oh, I'm sorry, I can't see it." And then you say, "Okay, come to the surgeon side. Maybe this is a better view." And I'll go in there and say, "How do you see it?" I say, "No, I don't see it. I just see a white fiber." And then he made this big sign and said, "JP, just believe this is lymphatics, okay? And then one day you'll be able to do it." and I came back and I started doing it, and my results were shit. I mean, it was bad. And that's why I had to do a lymph node transfer for several years before I went back and revisited, and then I started doing LVA. So in the beginning, it looks pretty how do I say, difficult, but don't give up. Ultimately, as you get better, as your skills get better, and be patient with your results, and then you'll start to really enjoy the surgery as well. This is definitely new science. It's ongoing. I mean, what we see nowadays is just preliminary results. I do believe definitely it works. Also, you have to have a fine, refined skill set. So start with your basic microsurgery and then ultimately go into smaller vessels, and you really enjoy doing LVA. But most of all, I think, this is a surgery that gives hope, because these patients have been neglected for ages. And I don't know if you know, but there's 90 million patients with lymphedema around the world. And primary lymphedema occurs in 1.15 out of 100,000. And these patients had really no hope. So I think what the surgery is giving hope to these patients, and this is what the surgery is about. And this is what reconstructive surgery is all about, is giving hope to the patient. So with that, I'd like to really thank you again, Avik and Greg, for the invitation, gracious invitation. And I'll be happy to answer any questions. Thank you so much.
Great. Wow. Thank you so much, JP. That was an incredible talk as always. And every time I hear your talks, I learn a lot. So I want to keep hearing more of your talks. But thanks again for this. It's definitely, it's good to see different approaches. And as you mentioned, other folks around the world like Mingwei and other groups do things a little bit differently. And so I want to open things up for questions, but I'll start with a question while people get their mics ready. So the deeper lymphatics is interesting because we're still doing the kind of subdermal lymphatic, LVA types, and we also prefer side to end I would agree with you on that. Let me turn my camera on. I'm sorry. Um, but I would we haven't done the deeper lymphatics yet. Clearly, I want to definitely try that. My question for you is: are you noticing that you need fewer LVAs when you use the larger, deeper lymphatics than if you do superficial ones?
Yeah, that's a very, very good question. I know that Aki from Japan, Aki Hayashi, he does all these crazy LVAs. He's also one of Dr. Kushima. He's also from Dr. Kushima's school. But he does basically the same approach, trying to find a deeper lymphatic. And he just does one.
Mhm.
He just does one good deep lymphatics. And then he's shown result that it works the same. I mean, I don't have the balls yet for that. I mean, if I see two large ones, I have to do it. You know, I mean, I just can't. I mean, I see it; it's there. I have to do it. You know,
Right.
And we haven't really tried single LVA, but according to him, he says it works. So I do believe it works, but I mean, it just makes more sense to me if you do more, probably the merrier.
Yeah, because people like you mentioned Wei Chen, he does sometimes 8 to 10 LVAs in a single case. So it makes sense that you would probably fewer if you're doing very large ones. So that's really interesting. Great. Any questions, Ed? Walter, I think you had a question?
Yeah, sure. Hey, thanks for that. That was really a great talk, as always. It sounds like this ultra high resolution ultrasound is really an exciting tool that I need to use the hospital to get. It sounds like, is that something that you're able to map? Do you map periodically in clinic to save OR time, or do you go to the OR and then map it in there?
Yeah. So the ultra high frequency ultrasound is around $125,000. The regular ultrasound from GE is also around $100,000. So does it make sense to have two ultrasounds? I think it does. I mean, the ultra high frequency ultrasound has really allowed us to know exactly where the functioning lymphatics is, where's the nearest vein. With the lower resolution, the chances of you finding a very good lymphatic vessel is not that high, because the resolution is blurry. But when you use that high resolution, you're actually able to see that lumen. Then when you see that, we know that that's functioning. So that has really reduced our operation time significantly, because now I don't have to go and explore. There's no exploration. I mean, of course you explore after the skin incision, but we know it's there. So this has really allowed us to implement so-called, I like the term functional LVA. And I think this is a total game changer. I truly believe so. So I hope that Greg will get you one.
Are you able to see the, will that show using Doppler mode? Will that show flow within the lymphatic channel also?
Yeah, that's a great question. The lymphatic flow is so slow that it doesn't show that, red or blue color. So that's why it makes a difference, and you're able to differentiate the vein and the lymphatics. So I think if it did, I mean, we're also curious to know what is the velocity of the lymphatic fluid. But right now, even with that ultrasound, we're not able to measure velocity.
And then have you gone back, like, a year later, 2 years later, to and use your ultrasounds to look at the flow? Because I imagine the velocity might be higher. That'd be pretty cool to examine.
Yeah, that's a very good question. I mean, we've toyed with this with the ultra high frequency not that long. So I hope to actually go back and see if there is any change in the flow. I think that's also a very good idea. I will ask around, the Japanese group who has a little bit more experience in using this ultra high frequency, and see if if they're able to see any difference post-op. But again, talking with Aki, he says that it's almost impossible to measure velocity even with an ultra-high frequency. But it would be interesting. It would be interesting to see the changes after 1 year.
I think before we get the hospital to buy us that ultrasound, I think I'd like to start a GoFundMe to buy Walter a new microphone.
Yes.
But Greg, I think
Hey, I have a quick question. It's kind of a dumb question. It has to do with Venturi effect. Can you hear me?
Yeah.
And so my thinking is the highest flow is out through the vein, right? And I would think that you'd want to take the end of the lymphatic vessel into the side of the vein to suck the venous or the lymphatic fluid into the venous system. Is that not true?
You could also do it like that. I think it will probably create a similar effect. But then my thinking is that I want to hook up something on the side of the lymphatics to collect from distal and proximal. That's why I like to hook up the vein to the side of the lymphatics. Now, if you hook up end to end, right? If you hook up end to end, you can still do it on the side of the vein, and it will probably work similarly. But again, then you have to do 2 lumens, 2 vessel to the side of the vein. So that's why I try to find the branch from the large vein, and then hook it up to the side of the lymphatics, just to do one anastomosis. Theoretically, I think it would probably be similar.
So the advantage is that you're taking from distal and proximal from your lymphatic vessel. So you're sucking fluid from distally and proximally into the venous system. That makes total sense.
Any other questions?
Thank you very much. Great talk. Fantastic. Really wonderful overview.
Thanks again.
So I had a quick question, if you have time.
Yes, go ahead.
Yeah. So how soon after LVAs, if they need liposuction, are you willing to let them have liposuction? And do you just avoid the areas you did the LVA? Like, do you have any tips for that?
Yeah, that's also a very good question. Wow, a lot of attentive people here today. So yeah, so actually my partner Peter, he's also a very good surgeon, and we're doing a study between secondary liposuction and simultaneous liposuction. So he's doing LVA, and then he's liposucking areas that are not near the anastomosis simultaneously. And I'm doing LVA, and then coming back 6 months later if the patient wants to do liposuction. Now, the idea, in my mind, the idea is, liposuction can possibly injure the lymphatic system. But we're ready to compare the study results. But anyway, when we have the results, we'll get back to you and actually give you more information. But for me, regarding your question, I'll come back 6 months later to actually do the anastomosis. And when I do it, I avoid the areas of the incision. Yes.
Okay, thank you. And then how soon do you let your patients after an LVA or even after just a lymph node transfer restart compression?
Oh, we do it on the table. We do it on the table, and compression on the table, and then we discharge the patient the next day. If the patient just did LVA, wow. Or if the patient did a flat, then we discharge the patient on day 4.
Awesome, thank you.
Great. Any other questions for Dr. Hong before we let him go to his 3 other lectures? Great. Well,
JP, thanks a lot.
Thank you so much. Incredible talk as always, and I can't wait to see you in person next time, hopefully. All right.
You guys, thank you for the invite.
Thanks again.
Have a great day.
Okay.
Thank you.
Bye.
Thank you.
Thank you.